Welcome to Newsoft's Medical Practice Management podcast series. I'm Lindsay Coates. The growth of telemedicine has left many people wondering why this hasn't taken root nationwide. Here to help me answer that question is Greg Billings. Welcome.
Thank you, Lindsay. Appreciate being here today and look forward to visiting with you.
Excellent. So, Greg, what is telehealth and telemedicine, and are the two terms interchangeable?
Well, actually, they are different, and it's defined differently depending on who you're talking to. But the Centers for Medicaid and Medicare Services do have a definition. Telemedicine is the more narrow definition that's used, and that is the actual transmission of healthcare data from a location where a patient is sitting to a location where a practitioner is, using video and audio, and it's required by CMS to be video and audio two-way communication. Telehealth is probably a broader term. Telehealth encompasses a lot more. Things like email exchange, facsimile exchanges, remote monitoring that might take place in a home where vital signs and pulse ox and what have you are transmitted electronically back to an agency that doesn't require the video audio communication. So telehealth is a broader picture. Telemedicine is a more narrow focus of two-way audio video communication.
Okay, so let's focus on telemedicine then. Take us through a typical visit.
Sure. Let's do a patient, an elderly patient who presents at a small hospital, a small rural hospital, and a hospital that doesn't have a neurologist. And that patient presents with a stroke or stroke-like symptoms. Now, the important thing in the stroke world is that there is a drug that is administered to, break up the stroke conditions, and that drug has to be administered within a certain time period. But oftentimes, it's very important that that drug be administered through the consultation and oversight of a neurologist. Well, that small community hospital that stroke victim or potential stroke victim presents to may not have a neurologist on staff. And so this is where telehealth can come in. If they have a telehealth connection to a larger facility with a neurologist, that neurologist can oversee and guide the prescribing and administering of that particular drug to that patient. Without that, the risk is a lot higher for that patient.
Gotcha. So far this sounds great. This is what a lot of people have been thinking. But what is stopping the nationwide adoption?
Well, there's a number of issues that stand in the way of that neurologist being able to get on the video, communicate into that small hospital, consult with the doctor on the ground with the patient, and have the drug administered. The first issue is licensure. If that specialist and the patient are located in the same state, licensure is really not an issue because presumably that neurologist is licensed to practice in that state. If that neurologist, however, is going across state lines and seeing a patient in another state, that neurologist has to be compliant with the laws, the state licensure laws of the state where the patient is actually located. So, unfortunately, each state law is not the same. So there's a checkerboard of 50 different laws, 50 different state medical board regulations and rulings on what constitutes licensure compliance in that particular state.
So it can get pretty complicated.
It can be pretty complicated. CTEL does in fact do research in this area and does provide that research to the community so they know exactly what they're dealing with in those particular states. The second thing is the issue of credentialing and privileging. The telehealth community had a lengthy discussion with CMS, Centers for Medicaid and Medicare Services, about this issue, and CMS is in the process right now of promulgating a final rule that'll streamline the process. Let me take a second and describe what that means. If a doctor walks in and wants to practice in a hospital, that doctor has to go through two steps, regulatory steps within that hospital's governing body. The first thing they do is submit their credentials, if you will. their license, their previous history, work history, etc. The hospital then rules on those credentials and verifies those credentials and makes the determination that that credential package presented by that doctor is accurate. Then that doctor, let's say it's a transplant doctor, and let's say that doctor in his previous life transplanted lungs and hearts. Well, that hospital may decide that they want a lung transplant doctor but not a heart transplant doctor. So they will privilege that doctor to only do lung transplants. That's all fine, and it works pretty well when you've got the doctor who is physically going to be located in the office. How does that work when you've got a telemedicine specialist sitting in front of a camera going into 7 hospitals during the course of the day, talking to patients all day long in various hospitals?
Right.
CMS was about ready to implement a procedure which said that that doctor had to be credentialed and privileged in every one of those hospitals. That would have essentially crippled the telemedicine program, both for these small hospitals and for the doctors themselves. CMS is in the process of streamlining that, and we have every reason to believe that that burden is going to be taken care of. But that would have been it probably would have crippled telehealth completely. Third, you have the issue of e-prescribing. If that doctor wants to write a prescription for the patient that they're seeing via video and audio, many states, and we're in the process, CTEL is in the process right now of inventorying all 50 states and their prescribing laws. Many states require that either a previous physician-patient relationship be established before the physician can write a prescription, or they require that the physician conduct an in-person examination of the patient before they write the prescription. Now, obviously, if you're 60 miles away on a telemedicine connection, it's a little hard to do an in-person examination, and in some cases, the doctor may be seeing a patient for the first time.
Right.
So there's another hurdle that on the prescribing side that the community is working on.
So any last things? What about reimbursement?
Reimbursement is a hurdle as well, particularly through CMS. I'll talk about 3 different areas: CMS, Medicaid, and private payer. With regard to CMS, the statute is very specific that Congress passed about how and under what conditions a telemedicine encounter can be reimbursed. The patient has to be in a rural location, not an urban location. The patient has to be in one of about 9 different facilities, a doctor's office, a hospital, etc. And the practitioner seeking reimbursement has to be in a certain category of practitioners. So it's done. There's a lot of telemedicine being done through CMS, but it is an extra hurdle. In the case of Medicaid, each state has their own Medicaid law, or their ability to have their own Medicaid programs. Many states are, in fact, opening up to the process of telemedicine because they see the benefits that are accruing from that. Some states are, for example, very aggressive in doing telemedicine in the prison system and are finding a lot of savings to their program, to their state budget, not in Medicaid necessarily, but in their state budgets. And some of that is translating to Medicaid because they're seeing that, the transportation costs that are going into getting patients to doctors can be far outweigh and the savings that would accrue to telemedicine, providing that same service through telemedicine. Finally, private payer laws. There are about, I think there's about 10 states that have passed statutes that specifically say that if an insurance company is going to provide insurance in that state, and if they reimburse for that particular procedure, if that procedure can be done by telehealth, then that insurance company cannot discriminate and not pay that as a reimbursable expense. Most of these states don't require any additional coverage or any additional services. They just simply say, if you're covering that service now as an in-person visit, If it's done through telehealth, you have to cover it through telehealth.
Was that part of the recent ARRA changes in 2009?
No, those are individual state laws.
Okay.
So those are individual states that have gone in and said, in our state, if you're an insurance company, you want to provide that service. If you reimburse for it in person, you have to reimburse for it through telehealth.
Okay, so it sounds like people are coming along and the insurance companies in the states are getting there, but there's some pretty deep problems that need to be worked out. So, in your opinion, does telehealth or telemedicine stand a chance?
Oh yeah, I mean it's here. It's constantly being pressed. I mean, think about the community now. I've got a 19-year-old daughter in college, and I sort of knew what Skype was a year and a half ago. I now know what Skype is, and online and the online web services. And I know at some point she's going to say to me, "What do you mean I can't see my doctor over a video camera and get a prescription written?"
Right.
The challenge for the community is, and the challenge for the regulators are, how do you ensure the safety of the patient, and get the services and tap into the technology, but at the same point in time, ensure the safety of the patient? Because just like anything else, you have a bunch of people out there who want to do things the right way. You got a few people out there who may not want to do things the right way. And the telehealth community doesn't want any negative backlash by those who are, shall we say, skate close to the edge. Right. So I think there is a future, and as people are more and more comfortable with cameras and video cameras and whatnot, there's going to be a lot more pressure for telehealth.
Sounds like there's a lot more advantages than there are any disadvantages. It's just overcoming some of the legal hurdles. So any last thoughts that you can give us? What about the future of telemedicine? What do you see?
I think it's going to come to a point where there's going to be more and more personal interaction within a person's home of communication and telemedicine. But people can just constantly be watching and make sure that when you have the opportunity to get the word out that telemedicine is an important aspect of the delivery of care, that they take advantage of that opportunity.
Well, that sounds great, Greg. I really appreciate you joining us today. Thank you.
Thank you very much, Lindsay. Appreciate it. Have a good day.
You too. Everyone, please make sure to join us next month for our Medical Practice Management podcast series. Thanks again.